To introduce myself, I'm Ant Kitchener. I'm an ACP in general practice, and as part of my wider ACP portfolio, I also do some management stuff and some stuff with education as well. Tonight's talk is around alcohol use disorders. So this is a phrase which is interchangeably used with things like alcohol dependency and some more older colloquial phrases like alcoholism. Okay, but alcohol use disorders is kind of the modern terminology. This session is not about sociology, it's not about psychology, but I do acknowledge the social and psychological impact of alcohol use disorders, but we'll focus more on the science this evening, so the pathology, and how that can inform your clinical thinking about which etiologies, which presentations are presenting in front of you. And I'm sure colleagues will recognise that a lot of patients with alcohol use disorders, dependencies, often access services time and time again, so can often be a reoccurring service user. And I recognise some of the patients that I've seen many times manage their care in general practice, right from early onset, even through to where alcohol has led to a fatal outcome. So I'm just moving on to the second slide, so I hope that's moving through okay. Let's talk about some science to start with. So in the body, we have a certain range we like, and it's a bit like Goldilocks. Goldilocks doesn't like her, the pudding that she stole, to be too salty, too sweet. She likes it to be just right. And in the body, there's loads of bits that represent the same theory. We don't like to be too hot, too cold. We like to be just right. Blood pressure too high, too low. We like to be just right because it means that we're performing. And we've got a pH scale or a hydrogen scale, which also likes to be just right. And when we talk about the pH of blood, we talk about that 7.35, 7.45 range, and we like it to be just right. Not too little, not too much, because that is out of range and that is disease. So I put a star up here, a Texas Ranger, and actually our job as health professionals is to keep people in range, or as I describe, a homeostatic ranger. So let's now talk about the problems which can go on, and the organ we all recognise as the problem that's affected by alcohol use disorders is the liver. Now, we've got patients that are drinking and drinking chronically, alcoholic, high content alcohol, and that enters the body. So my first question is, how does it kind of get from body to liver? And we can think about that journey, but we can also think about when it gets there, the damage it will do. So damage can happen to liver, but also other organs, and we'll talk about other organs a little later. But think about the function of the liver in terms of what the liver does. So the functions of the liver include protein synthesis. So it makes all your proteins, your albumin, your globulins, like your immunoglobulins, your fibrinogens, so stuff for clotting, amino acids, iron binding proteins and copper binding proteins. So loads of proteins are made in the liver. So alcohol use disorder can lead to liver disease, which means all your protein synthesis will be squiffed and not working. So already 5 or 6 areas there which can go astray, and they can lead to problems down the line. Liver is also responsible for biosynthesis, so making your biles, your bile acids, your cholesterol, a yellowy chemical called bilirubin, that bilirubin bile pigment, and also your electrolytes. Your liver has a load of responsibility for storage. So if you screw up your liver, your storage capability changes. Think about your fat-soluble vitamins, vitamin A, D, E, and K. Also, there's functions around glucose, iron, copper, vitamin B12, think about pernicious anemias. And then also the liver has functions around getting rid of waste, ammonia, urea. If you don't get rid of all your ammonia, it affects your brain. You get an asterixis, a a kind of shaky hands type syndrome, a bit like you'd see in a CO2 retention flap, so similar type of presentation, correlated clinically. You can't detoxify estrogen. You start to get red palms, palmar erythema. You can't get rid of alcohol. You can't break it down. And also all your other toxins. Think about all the bits in the liver that break down all your toxins. So your P450 cytochromes, complements, and so forth. At any one time, the liver is also full of blood, around 10% of your blood volume, and probably about half of all your lymph in your body as well. So it's a busy little organ, and also the liver is responsible for keeping you warm. So it's your main generator of heat in the body, mainly because of all that metabolism. So if we mess this up, we've got around 25, 26 functions that go wrong, secondary problems, and that's just the liver. There's other organs that it obviously affects. And if we just remind ourselves about the anatomy of the liver, the main blood vessel into the liver, which drains all the tummy stuff, so your gastric stuff, is this big portal hepatic vein. So all the stuff basically below the diaphragm drains in via this portal vein, and that's the main motorway, if you like, into the liver. And where problems happen in the liver, the backflow from that will have problems downstream, and we'll describe some of those in a few moments' time. And then if we think more micro, we think about what's the liver made up of. Well, the liver's made up of cells, and we call those cells hepatocytes. And they're rows of hepatocytes that have all these functions, so that protein synthesis function, that storage function, that biosynthesis function, that detoxification function. And then also between these hepatocytes, there's other cells. There's cells which are responsible for immune response, loads of sludge going through this liver, so lots of bugs to think about as well. And also some storage cells outside the hepatocytes, such as ones that store vitamin A. So a busy place and plenty of options to get this wrong. So let's think about that journey then. So we go into a patient's house, and you're potentially presented with 20, 30 empty bottles of alcohol. You can think about your choice that you see, your Frosty Jacks, your White Lightning, your Special Brews, whatever the brand is. And that has got into the body. So it's gone in through the oropharynx, they've drunk it, down the esophagus, into the stomach, and it empties into that duodenum, that first part of the small intestine. So what is actually happening there? So there is some contact damage that will occur. So we know that normally stuff can get absorbed through that duodenal wall, through those cells, cells of that lumen. So you can normally get some stuff across, but not all stuff, only the stuff that we want to. So some of the nutrients will absorb through there, and alcohol permeates reasonably well through there, so it can get into the blood fairly well. But normally, in a state of health, we usually keep a lot of the bacteria within the gut. Naturally, we need gut bacteria. It lives in harmony. It's what we describe as this commensal or harmonious bacteria, normally gram negative, and it just lives in harmony, and you have your balance of your gut, your flora, fauna of the gut that keeps you, that gut flora keeps you balanced, so you don't get too much diarrhea, for example, and also you don't get constipated. But what does chronic alcohol use do in this situation? Well, actually, the mucosal layer that lines all these cells will get damaged, and it will unbalance this bacterial level. In fact, it will promote bacterial growth of a certain type, and it will wipe others out. So you get this unbalanced, and that unbalance will start to affect the walls of the cells. So these cell walls become more permeable, more holes in them, and therefore stuff that shouldn't get through can start to get through. And the culprit that we're going to talk about here are some of the antigens that sit on the bacteria, called LPS antigens. These lipoprotein or polysaccharide antigens can get through and they shouldn't get through. So we've got stuff in the blood, which normally under healthy conditions is not there. And that's one of the main effects of alcohol use disorder that can lead to. Okay, so let's take stock of where we're at. So we consume our beverages on a chronic fashion. We get increased bacteria, reduced mucus, and increased gut wall permeability. And we now get footprints through that should not get through. These LPS antigens enter the blood, the gastric veins, and they go up into the portal vein. And where are they heading? They're heading to the liver. So this is the journey which shouldn't be happening, but due to the chronic use of alcohol is happening, and this becomes our challenge. So here's a diagram that represents the portal vein, that main motorway into the liver, and we've got to think about what happens. Well, I said we've got a couple of cells in the liver. So as it enters, there's a couple of cells that get activated. We've got these things called Kupffer cells, and we've got some stellate cells, and they're the two that mainly react. So Kupffer cells are up first, these immune cells, and these are a type of macrophage that will fight and recognize potentials of aliens coming in. So the alien it recognizes is this LPS, and through its little receptors, its tollate receptors, it will recognize these. So because it's been stimulated, it's recognizing this bad guy that should not be there. It starts to have an immune response. And part of that is it starts to get other cells come in to help. So these white blood cells, these neutrophils, as well as these macrophages to come to this area. And it secretes a load of cytokines, these inflammatory cells, TNF alpha, tumor necrotizing factor alpha. Now that doesn't sound healthy, does it? And these interleukins, interleukin 1, 6, and 12. And these are all pro-inflammatory. So because of this journey, alcohol's screwed up the wall, LPS has got across, LPS has been recognized, and now because it's been recognized, inflammatory cells are starting to flood. And we start to get an inflammatory response in the liver. And what do we call inflammation in the liver? Hepatitis. So we've got an alcoholic hepatitis going on, and that is painful. So we'll correlate this clinically with abdominal pain. Now, don't forget, another cause related to this could be pancreatitis. That's another organ that gets affected and can also cause abdominal pain. So biochemistry will help differentiate that. But, liver pain is tender. So we get this inflammatory response where we start to get macrophages and neutrophils causing an inflammatory response. We also get activation of these stellate cells. Now, stellate cells are usually docile, sleepy, and they're usually full of vitamin A. So they're a vitamin A storage cell. But actually, when they get insulted and, the Kupffer cells get overwhelmed a little bit, they will go, whoa, I'm not having this. I will dump my vitamin A, and actually I will get involved in this. And through a process of more cytokine release, they will start to have an inflammatory effect. They'll add to this inflammation. But also one of the chemicals down the line, particularly this interleukin 8, will start to lay down collagen and fibrinogen. So they will turn into this myofibrocyte. So they'll start adding coarse, stiff material within the liver. So we start to see these hepatocytes get laid down with fibrous tissue. So it becomes stiff and hard. And this is starting to contribute to that position of cirrhosis that we get in the liver. So we've got an inflammatory process, hepatitis, inflammatory liver disease, and we start to get towards this hard and stiff liver disease. And as these hepatocytes become hard, stiff, unusable, our liver starts to fail. So an interesting concept that actually, because of alcohol in the gut, stuff that's got from the gut into the blood, from the blood into the liver is recognizing it as an alien. It shouldn't be there. It's an insult. And actually that then moves into a position that it starts to damage the cells, inflammation, and then later on down the line, fibrous tissue. So this is contact damage. But in addition, I mentioned about that pH scale, didn't I? So we mentioned that the pH scale could be insulted as well. So what's actually going on with the alcohol metabolism in the cells? And how does this contribute to a state of poor health? So just to recap, increased bacteria, reduced mucus, increased holes in the wall, LPS gets in, we're now getting macrophages, neutrophils, inflammatory, and then actually that inflammatory state starts to really have fibrous scarring, and the hepatocytes start to get damaged and become depleted in function. So now we're going to talk about the ethanol in the cell, the alcohol that's got in, and how that would normally be metabolized. So there is a metabolism process to get rid of this. And we talk about metabolism of ethanol, and we usually use an enzyme called alcohol dehydrogenase. And we use this quite a lot. And actually, normally, you've got some, you drink some alcohol, you use it, it breaks it down, you get rid of it. It gets overwhelmed, you become a little bit tipsy and then toxic, so you become drunk. And, eventually your body catches up, metabolizes it, and you get rid of it. But what happens if you continually top up the alcohol, this dependency, it keeps going and going, this becomes overwhelmed. So in essence, our ADH upregulates, and that conversion continues and continues. ADH is converted into another chemical, and that chemical has hydrogen ions attached to it, and that is an acidic process. And if we run out, we become overwhelmed, we're left at one of these stages. So ethanol into acetaldehyde, a toxic chemical, or if it gets stopped at the acetate, acidic acid, acetate, again, an acidic chemical. So we've got this pushing towards the acidic range going on in the body. So by virtue of screwing up our metabolism of alcohol through chronic use, we potentially could imbalance our pH scale more towards the acidic line. Now, the other thing that further on down this pathway, that acetyl-CoA at the bottom, that then gets converted into fatty acids, and broadly we make more fatty acids when we've got alcohol abuse going on, or alcohol use disorder, alcohol dependency, and we also inhibit the breakdown so we don't get rid of it. So lots of fatty processes going on, and one of the things that we see in liver disease is fatty liver disease, because we cannot get through this process from ethanol to acetaldehyde to acetate to acetyl-CoA, then into fatty acid to get rid of it. So we get fatty buildup within the liver, and that's really easy to see. So we see that on scans, and actually you can feel that palpable. Sometimes you get this hepatomegaly. Now, this is 75% of the ways we do it. There is another pathway, a 25% pathway. So most of it is via this normal ethanol, acetaldehyde, acetate, acetyl-CoA pathway. But the other pathway, 25%, starts to become more active if the other one just gets overwhelmed. Now, this little pathway metabolizes into other products, but we don't use it as much because they're toxic. So it creates free radicals and a chemical called hydroxybutyrate, again, an acidic chemical. So again, it adds to this acidic picture, and we start to go into an acidosis and a breakdown, a ketoacidosis type presentation. And you'll be familiar with that word from diabetic ketoacidosis. So a similar type process. So as I've described, the fatty acids become more, but the actual breakdown becomes less, and overall we become fatty. So if we talk about the states of liver disease, healthy liver, optimal, you now know the pathophysiology for fatty liver disease. Because of this process, we can't get rid of our fats and we can't break them down. We've talked about that inflammatory process, and we've also talked about that cirrhotic process where it becomes fibrotic and eventually cirrhotic as we lay down collagen and fibrous bands within the liver. And the combination of both contributes to the overall liver disease and over time dysfunction. So what happens if we use this alternative pathway opposed to the main pathway more and more? Well, actually, the result of this is we start to make DNA adducts, which are mutations, and we start to see mutations within the cells. And actually, no one likes mutation in the cells because that adds to a level of pathology that we wouldn't overly see otherwise. So we've got this overall acidic buildup. So the risky bit for these patients is that pH imbalance, that abnormal homeostasis, and that can be fatal in its own setting. But there's more. As if this was not bad enough, there's more. So let's talk about some of the mores, the things that go wrong in addition. Let's talk about the backlog. So we've screwed up the liver through this process of pathophysiology that we've described. But, you know, there's a queue, this motorway in, this portal vein, there's a queue. So what's going to happen? We're going to get a sludge. The pressures within the portal vein will go up. We'll get portal hypertension. And that will lead a backflow, a backlog, a back pressure within the portal vein. And where can that back pressure go? Well, it can go down the gastric vein. It can go down that mesenteric vein, down the splenic veins. So it will go back to the original organs. And that in itself will start to cause issues. Okay. So what are those issues that we'll start to see? Well, if it goes up to the veins around the esophagus, we'll see engorgement of those esophageal veins, what we know as esophageal varices. And when the pressures become so much, we get bleeding esophageal varices, and that is often fatal. I recall plenty of patients that I've been to dead on the floor, and actually esophageal varices was the cause, and alcohol use disorder was their background. The other end of the spectrum, hemorrhoids. So these patients will often have complications with hemorrhoids, and they will bleed and they'll be painful. So hemorrhoids is often a local problem, but could it be traced back to a pathology? What about the pressures in the spleen? Well, actually, if it goes back, the spleen starts to become engorged and enlarged. So we start to get splenomegaly. And actually, you can palpate splenomegaly. So, you know, if you start down in that right iliac fossa, palpate diagonally across the belly, sometimes you can palpate it. Now, we should have one spleen. It should measure around 3 by 5 by 7 centimeters, about the size of your fist. But you can see in this scan here, that is not the size of the fist. It's got massive enlargement. Now, is that a problem? Well, I would argue it is, because the spleen has functions. The spleen has functions around red blood cells. So if your red blood cells can't get out, what happens? It has functions around platelets, so your thrombocytes. So if your thrombocytes, your platelets can't get out, what happens? It has functions around immune cells, so white blood cells. If your white blood cells can't get out, what happens? Well, I'll tell you what happens, problems, and these patients become more complex than they need to be. So these splenic disorders, you can't get your red blood cells out, your patient becomes overall anemic. And actually, because of that, the cells that are left have to swell and try and go harder. So you start to see a macrocytosis, big swollen red cells. They become thrombocytopenic, they're circulating platelets drop down. And if you think about the function of platelets, they're there to stop you bleeding. So if you can't stop bleeding, imagine you've got those pressures, burst esophageal varices, and you can't clot. Or even hemorrhoids, hemorrhoids that drip blood, you can't clot. You could get anemic from that process. So anemia on anemia, and we know that leads to further pathology. And in leukopenia, if you can't get your white cells out, you become immunocompromised. So these patients are at high risk of infection. So all these downstream problems from the result of the portal hypertension, all stemming from that alcohol in the gut, the LPS crossing, to you getting these inflammatory responses, these fibrous responses, and then those portal hepatic pressures increasing, backlog, gastric vein problems, splenic vein problems, mesenteric vein problems, they start to pile up. So these start to add to the likelihood that this patient will die of something along these spectrums. So once this becomes totally congested, where's those pressures going to go? And they start to have pressures on the walls of the vessels. So the fluid tries to get out. So it starts to force itself through the walls of the vessels, and fluid starts to get into that peritoneal cavity. And we start to get engorged veins that we can see, and we start to see something called ascites. So here's some distended veins that you can see. Might be a characteristic presentation, a clue that it's going on. And then this classic ascites presentation. So the abdomen is full of fluid, and it can be like a drum tightness. If you pop your hand on it and bounce it, it will sound like a drum. And actually you can do a fluid shift. You roll them a bit like if you had a bottle of something. And so I've got a bottle here with fluid in the bottom. If I turned it, the fluid turns, and the same principles with the patients. You might be able to work out where the air dome is, but if it's that much fluid, you might not even have an air dome. So this patient gets all their organs compressed, and that makes them really uncomfortable. And the treatment for this short term might be a tap, a drain to drain off some of the ascites, but if you don't correct the problem, you end up reoccurring ascites. Now, what's the trouble with ascites? Well, it's warm, it's wet, and it's full of bacteria. Those LPS antigens are floating around in this. So it's warm, wet, full of bacteria, a prime growth site for infection to grow. And not only that, we've said there's splenomegaly. So we haven't got those immune cells floating around like we need to. So a warm, wet, productive area for bacteria to grow with no immune response is a recipe for a sepsis, a fatal sepsis. And we know sepsis leads to shock, and shock leads to death. So a whole contributory pathway and another option which could see the demise of these patients. Now, I've said about other end organ damage, so it's not just the liver, so we have to be mindful. Direct effect of alcohol on cardiac cells. We see a cardiomyopathy, a dilated cardiomyopathy. The heart becomes bigger, baggier, and it basically contracts less efficiently. So we start to see a heart failure presentation, and we can see abnormal arrhythmias. So arrhythmic death could be associated with alcohol use disorders. So if infection, anemia, bleeding, and all the other causes don't get you, this is on the list of possibilities. So direct effects on the heart. Direct effects on the brain. Now, the alcohol in the brain has lots of effects on neurotransmitters, everything from GABA, that inhibitory brain chemical, so a GABA agonist, to a lot of the other ones, so your serotonin and a load of other chemicals, but also has direct effect on the brain tissue itself. And we can get this Wernicke-Korsakoff syndrome, which is a psychosis and encephalopathy. So you can get a sudden psychosis, a sudden mental health presentation associated with alcohol use disorder. And you can get kind of this dementia encephalopathy with it as well. And for this reason, we put patients on thiamine, and this vitamin B1, and often vitamin B strong compound to protect them from Wernicke-Korsakoff syndrome. So these patients that you go to, you look at their meds, you're like, you're on vitamin supplements. It could be for alcohol use disorder. And if they've stopped taking these, or they're not good in terms of their concordance, it could be that. And the presentation might be this acute psychosis, acute dementia type presentation that has kicked in. So the end stage damage in terms of the end stage organ in this case is the brain. So it's not painting a pretty picture, it's a systemic pathology that's going on. And I just want to talk about some of the other areas which can be affected. So as if the local stuff, isn't helpful. So we've talked about, the local stuff in terms of the gut, the LPS into the liver, the fibrous tissues. So we've got hepatitis, we've got cirrhosis going on, we've got fatty infiltration going on. We've talked about, the intracellular stuff. So we've got an acidic process going on in terms of we can't break down, and we've got fatty processes going on. So we get fatty in the liver. We've talked about the backflow. So we're starting to get that portal hypertension. We're getting everything from esophageal varices to hemorrhoids, to that splenomegaly and the problems of anemia, thrombocytopenia, and issues with anemia associated with that, as well as the bleeding. We can't clot. We've talked about that hydrostatic pressure. So we're getting into the ascites, that warm, wet, bacteria breeding area. We've talked about cardiomyopathy. We've talked about Wernicke-Korsakoff syndrome in the brain. And can it affect other organs? Well, yep, there's other syndromes associated with this. Hepatopulmonary syndrome. So you can get hypoxic presentations where you start to get a VQ mismatch as the capillaries around the alveolar start to go squiff. We can get hepatorenal syndrome. So hepatorenal syndrome, the kidneys start to become affected. And we know the kidney controls blood pressure. So you can get blood pressure issues associated with this. And we know kidneys contribute to the balance of electrolytes. So if your electrolytes weren't squiff already because of your liver disease, they can start to get squiff because of the hepatic problems. We also know that alcohol is really sugary. So we start to get, lots of urination. So they start to wee lots and lots, and that can actually give you an electrolyte imbalance as well. We talk about the pancreas, and we've talked about both acute pancreatitis, but you get chronic pancreatitis, inflammation processes within the pancreas. And we know the pancreas is responsible for producing insulin, for your glucagon production, as well as your somatostatin, as well as the other 98% function is around gastric juices, your lipases, proteases, etc. So you start to get gut upsets, and you've already got gut problems, and you start to have problems with your sugar. And we also know the liver balances off sugar as well. So combined together, you start to get, this diabetic presentation can crop in as well. There's issues around alcohol withdrawal syndrome. So because of this dependency and the way everything's balanced, acute withdrawal can give you issues. So we talk about delirium tremors, shakiness, and therefore, we should never acutely stop alcohol use. It should be a detoxification program with the combined psychological support that has, because we know it's really, really tough to detoxify and de-dependentize yourself when you've got a dependency syndrome. I will say the one to watch out for with alcohol withdrawal syndrome is temperature. So it can affect the brain, the hypothalamus, and if they present febrile, that's usually a bad sign. And we also know that they can go into seizures, and seizures have their own complications, both neurologically, but also the risk of hypoxia. And occasionally we see people die from the seizures elements where they've gone hypoxic, and that's been the fatal demise of them. And the final bits I just want to describe, I started by saying this isn't a psychology lecture, this isn't a sociology lecture, but this is such a massive part of it. And the social connections we often see things like support networks falling through, breakup of marriages, loss of friends, loss of jobs, so that function in life, and that will contribute to mental health issues around dementia, around depression syndromes and anxiety syndromes. So again, a contribution factor, which often means they're in a vicious cycle and really struggle to kick the habit, to kick the dependency. So why am I telling you this? Well, I remember days in my practice where actually I focused just on the social and psychological elements of the presentation. And because sometimes we see patients time and time again, sometimes we can get a little clinically blasé around their presentation. They're back, again, what's going on? But actually, there is so many challenging and different dynamics to alcohol use disorder. Every end stage organ, their pH levels in terms of their balance, the risks that go on throughout the whole system. It's such a systemic pathology that it is on my low threshold list for admission if I'm not sure what's going on. And we often see fatal outcomes associated with alcohol use disorder. And I'd go as far to say is this disorder is worse than drug use because of its complications and its far-reaching influence within the body. So that brings me to the 45 minutes that I was going to describe, just leaving a little bit of time to talk around questions.